the topic that is the urinary bladder. Myself, Dr. Sharmishtha Ghodke from Anatomy Department. Already you have seen the one bladder, that is the gall bladder. So the function of gall bladder was it stores bile. So similarly, the urine is stored by the urinary bladder. Now, if we look at this organ, it is totally muscular hollow bag, which acts as a reservoir of the urine. And the site, as you can see in a picture, it is situated in the lesser pelvis in the anterior aspect. The muscle which is present is the detrusor muscle. Even if we say it is in the lesser pelvis, the site varies depending upon the age and as well as the bladder, it is empty or full, depending upon that. So in children, even if the bladder is empty, it is abdominopelvic, and also full, it is abdominopelvic. But in adult, the empty bladder is present in the pelvis or pelvic cavity. And when it becomes full, then it becomes abdominopelvic. The shape of this bladder when it is empty. So first we'll study the bladder when it is empty, and which is more important because for exam and viva point of view, you should be able to identify and show the surfaces of it. So it is tetrahedral in shape when it is empty and becomes ovoid when it is full. The capacity again of the bladder, mean capacity is 220. In children, it is 20 to 50 ml. Anatomical capacity, if we see, it is 1 liter, and physiological is about 50 to 450. The first desire you get to micturate is when the urine is stored about 150 to 250. When it becomes above 450, then the painful sensation person gets. And beyond the voluntary control, the bladder urination goes, that is when it is 800 ml. Now the tetrahedral means, we know tetrahedral means it should have 4 sides. Okay, so the 4 sides are there. The main parts of the bladder is, one is apex, another is base or the fundus, then lower down, that is the neck, as you can see, and also the body of the bladder. The surfaces of the bladder is one which you can see in the diagram, that is the uppermost, which is the superior surface, extending from the apex to the posterior border of the bladder. Then 2 inferolateral surfaces. The inferolateral surfaces, as my palm showing, these are one which are extending from the apex. In between 2 inferolateral surface, you get the anterior border, as you can see. The base, which is directed posteriorly. So these are the superior surface, 2 inferior and base. The borders, as I told you, anterior border, posterior, and 2 lateral borders which are separating the inferolateral surfaces from the superior surface. Now coming to the apex of the bladder, which is pointed forward, which gives attachment to the median umbilical ligament. The ligament from the apex runs upward and goes and gets attached to the umbilicus. Okay. So the apex is directed towards this pubic symphysis. Now coming to the fundus or the base, which is directed backwards. Okay, so it is a posterior inferiorly. It is triangular in shape, as you can see in the diagram. The posterior surface of the bladder, which is triangular in outline, the relation of it varies in male as well as in female. So in the male, posterior aspect, upper part up to the seminal vesicle is covered by the peritoneum. Okay, and below, lower part is related with the seminal vesicles and the ampulla of ductus or vas. Okay. The vas is medially and seminal vesicle is laterally. As you can see in the lower picture, the upper part of it will be covered by the peritoneum. The part which is not covered by the or non-peritoneal, we call it as a external trigone. So as there is external, there is internal trigone. We'll see in the interior. The relations, so as I told you, these are the relations in the male. Now coming to the female, as there is in between the bladder and ampulla of the rectum, you get a uterus. So the relations in of for the base of the bladder are upper part of the anterior wall of the vagina, above that supravaginal part of the cervix, and in between the two, there is a loose areolar tissue that is of the pelvic fascia. So this is about the posterior relations in male as well in female. Coming to the diagram, as you can see in both the diagrams, in the female pelvis, you can see the bladder. Then you are seeing the uterus. The posterior base is related with the anterior wall of the vagina and supravaginal portion of the cervix. Okay. And there is a loose areolar tissue. In case of a male, the base is related with the seminal vesicles. Then the vas you can see, ampulla. And also there is a rectovesical fascia, and behind that there is a rectum ampulla of it. Now coming to the body, which is a large situated, it is superior surface is situated between the two lateral borders, and the relations here for the superior surface. The superior surface, it is covered by the peritoneum. You can see here it is covered by the peritoneum. This is peritoneum, and it is related above that with the sigmoid colon on the left aspect, and also the coils of the small intestine. And in the female also you get the anterior surface of the uterus when it is anteverted. Uterus is anteverted. Then coming to the inferolateral surface, as I told you, these are the inferolateral surface which are directed downwards and laterally. And the relations here are the related, the surface is related with the, as you can see in this picture, there is a pelvic surface of the body of the pubis symphysis and the fascia covering that to levator ani and the obturator internus muscle. You can see both the muscles over here. That is the levator ani and obturator internus. This is the how you, if you look from the inferior aspect of the bladder, you can see on either side the inferolateral surface. In between there is an anterior border. On either side, you can see the entry of the ureter. And in between these two, there is the line that you can see here. This is the posterior border. Now coming to the space of rings. This is important for the short note or also for your MCQs. The space of the rings, which is present behind the pubic symphysis and body of the pubics. And it is situated on the lateral aspect of the urinary bladder. This space, the importance of the anatomical importance is this space acts as a bursa for the distension of the bladder. Now, as you can see here, the boundary so will be the anteriorly you get a pubic symphysis. Then there is a body of the pubis. Behind it will be related with the posterior true ligament of the bladder. Above there will be the peritoneum of paravesical fossa. Below you get the puboprostatic ligament or pubovesical ligament, depending upon the sex, and the pelvic fascia. Medially, it is related with the on either side, that is the inferolateral surface. And laterally, it is the fascia covering the levator ani and obturator internus. So as you can see here, this is a horseshoe-shaped space, the space of rings. Now the contents here are, as you can see here, this is the vesical plexus venous plexus, which is present in this space, and also the retropubic pad of fat. The importance is the bladder and prostate are approached through the space. The surgical importance here is that you can, when there is a, you make a bladder full, or when it is a full, you can approach through this space. So the approach is extraperitoneal, and you are not entering file surgery into the peritoneal cavity. Now coming to the anterior border, as I told you already, this is a border between two inferolateral surface. The posterior border, you can see that is joining the entrance of the ureter, and it separates the superior surface. The lateral border, as you can see here, dotted one, on either side you get between the superior and inferolateral surface. And between the apex, extends from apex till the ureter. The body is large area situated between the apex and the fundus. The neck of the bladder, as you can see here in the picture, it is a constricted part that leads to the urethra down. You can see here from the neck, the urethra starts. Okay, the neck is about 3 to 4 centimeter behind, 3 to 4 centimeter behind the pubic symphysis. And this neck is one which is fixed one. Okay, even if the bladder becomes full, the neck is not going to move. In case of female, the neck is at the lower level in contact with the superior fascia of the urogenital diaphragm. Now the distended bladder, as you can see, it is ovoid, and so it has got two surfaces, that is the antero-inferior, we call it as antero-inferior, and posterior-superior surface. So this is the antero-inferior and this is the posterior-superior surface. Then two lateral surfaces and the summit of the bladder and base and neck. Now antero-inferior surface is non-peritoneal, extends up above the pubic symphysis. Posterior superior is, again, it is posterior superior surface is peritoneal, one related with the sigmoid colon and small intestine, and in female it is related. Now the lateral surface is partly peritoneal when the bladder is full, and partly non-peritoneal. Base and neck are the fixed part, as like same as like that of the empty bladder. Now coming to the ligaments of the bladder. To say the ligaments, you have to know that there are some false ligament and there are true ligaments. The true ligaments means they are the thickening of the deep fascia, and also some smooth muscle fibers are there. But the false ligament means they are just the peritoneal folds. So the true ligaments are 9 in number. Okay. And they are the direct anatomical supports. Okay. Coming to the true ligaments, as you can see here, the true ligament which anchor the bladder, and out of these 9 ligament, only one is a unpaired ligament, and other all are the paired one. One which is unpaired is the median umbilical ligament. So median umbilical ligament, we saw that from the apex, which goes towards the umbilicus, and it is developmental. This ligament is a developmental, means it is a remnant of urachus, develops from allantois. Coming to the other ligaments which are paired one, as you can see in a picture, the true ligaments, that is one, that is the medial and lateral puboprostatic, or in female pubovesical ligament, which connect the urinary bladder with the inferior aspect of pubic symphysis. Now the coming to the, so these are the 4 ligaments. Now coming to the lateral ligament extends from inferolateral surface of the urinary bladder goes laterally and to the tendinous arch of the fascia. You can see here the tendinous arch of the fascia to which the ligament gets attached laterally. The two posterior ligaments which we see, those are from the side of the base of the bladder to the lateral pelvic wall, and it contains the plexus of vesical veins. The Fons ligament, as I told you, these are the peritoneal folds. So they don't have much role in the support of the bladder. But these folds, they are 7 in number, one already, that is the median umbilical true ligament, which has some one peritoneal fold, that is the median umbilical ligament. On either side, we get the medial umbilical ligament. No lateral umbilical here in the falls. Then there is a lateral ligament, that is laterally there is one peritoneal fold, and another is the posterior ligament, that is the sacrogenital fold, which are on either side, which are from the lateral angle of the base backwards into the S3 vertebra. So in this picture, we can see the medial and lateral, medial and lateral umbilical ligament. Now coming to the bladder bed, as we saw, stomach bed means on which stomach lies. Similarly, the bladder is situated on some other organs or the parts that the structures on which bladder lies, that is the bladder bed. First is the symphysis, pubic symphysis, body of the pubis, then fascia covering the levator ani muscle, then the obturator internus for fascia, retropubic pad of fat, the retropubic, there is a pad of fat, then ampulla of the rectum on which it lies, or the anterior wall of the vagina in female, the base of the prostate, or the superior fascia of urogenital tract. So these are the structure on which the bladder lies or forming the. Now coming to the interior of the bladder. To see the interior of the bladder during this section, we have to cut along the lateral borders of the bladder from the apex and then reflect the superior surface, as you can see in the picture. So you can see the interior. Now, when you look at the interior, you can see a lot of the mucus folds making the surface irregular. And these folds are one which are which disappear when the rugae disappear when the bladder distends. There is one area in the interior which is not showing rugae or the folds. This is called as a trigonum vesicae. Trigonum vesicae. Trigonum means triangular one, vesicae in the bladder. So you can see this triangle has got 3 sides and 3 angles. So it is formed, it's area where no folds are present and the mucous membrane is tense, glistening, and it is adherent to the underlying surfaces, and there is no submucous coat. Now, the apex of this trigone is formed by one, that is you can see here, that is the opening of the urethra. Ostium means opening of the urethra, urethral opening. This opening is crescentic in shape, Then the other base is formed by these are the 2 openings of the ureters or ostium uretrites. The band between these 2, that is called as interuretric ridge. It is called as interuretric ridge or Mercier's bar. So this bar forms the base of this trigone. When it is empty bladder, the distance between 2 openings of the ureter is about 2.5 centimeter. Another thing you can see here, see, this is the ureter. When it enters into the wall of the bladder, it makes oblique pores and then opens into the bladder. So this pores, which is called as intravesical pores of the ureter, there you can see the mucous membrane fold. Now, one more thing you can see just behind the opening of the ureter, you can see a structure called as uvula vesicae. It's a small rounded projection of the bladder mucous membrane. It is more prominent in old men because this is due to the enlargement of the middle lobe or median lobe of the prostate. The importance of this clinically is this is going to many times when it enlarges, it obstructs the opening of the urethra, and then there is a no proper emptying of the bladder. The structure of the mucous membrane will be transitional epithelium. You will see in detail during the histology, but there is a trigonal muscle of Bell, and that will replace because there is no submucosa here. Loose areolar sheath is the fascia of Voltaire, and the muscle that is the detrusor. What is the importance of this trigon? So trigonum vesicae, what we saw, it is a fixed one, dependent part. So as it is dependent, whenever there is a stone in the bladder, when the bladder becomes empty, stone goes and touches this area. So this area, as it is richly supplied by the blood vessels and nerves, the patient will experience severe pain as well as there is a bleeding and inflammation of this area when there is a stone. This area develops from the mesoderm. The applied aspect of trigonum, remember, is the prostate enlargement. There is a enlarged uvula vesicae and obstruction to flow. The Pell interureteric ridge, which we saw earlier, that is between the two openings of the ureter, there is a bar, that is Mercy's bar or interureteric bar. This is a pale one, and that helps or that guides you to enter into the ureteric opening. Okay. Sometimes the ureteric opening appears like a golf hole in cases of tuberculosis of the kidney due to the shortening of the ureter. Coming to the blood supply, the superior vesicle and inferior vesicle, which are the branches of interiliac, which is a branch of common iliac, and also the obturator artery and the branch of inferior gluteal artery supply the bladder. In case of female, sometimes the uterine gives a branch to supply the bladder. The venous drainage here is a vesical plexus of the veins, as we saw, which is present in the near the inferiolateral surface. They communicate with the prostatic plexus and then drain into the internal iliac vein. The lymphatic drainage here is the lymph of the bladder drains into external iliac group of lymph nodes, apex and inferiolateral surface into the anterior group, upper surface or superior surface into the intermediate group, and the base into the posterior group. The nerve supply of the bladder is important. Read it properly. Little bit difficult to understand. So like all organs, we divide it into sympathetic and parasympathetic fibers. So the sympathetic fibers which arise from the T11 to L2 in the spinal cord, these are the preganglionic motor fibers from the superior hypogastric plexus near the sacral promontory, and then give rise to right and left hypogastric nerve. It gives rise to right and left hypogastric nerve, which will reach the neck and the bladder. The sympathetic stimulation when occurs, the sphincter vesicae will be stimulated and inhibits the detrusor muscle. So this nerve is the nerve of feeling, means the detrusor will relax. So the urine can store it. So that is when the sympathetic stimulation. Painful sensation is carried by the sensory sympathetic fibers from T11 to L2 spinal. So coming to the parasympathetic supply, The pelvic splanchnic nerves, which originate from the S2 to S4, these nerves carry signals from the detrusal muscle. When the sensation from this, they carry the sensation. Nerves carry the signals to promote the detrusal muscles to contract. So parasympathetic stimulation causes contraction. So the nerve to empty. So parasympathetic fibers are for empty and sympathetic are for the filling. Now the postganglionic neurons are with the bladder wall and supply the detrusal and muscles of the proximal urethra so that can dilate by empty. The bilateral destruction of the pelvic splanchnic nerve produces detrusor paralysis and now something about the histology we'll see in detail later on. So there is a urothelium, or it's called as a transitional epithelium, that forms the mucosa. Then there is a muscularis propria, serosa. Okay, so you can see under later on urothelium, superficial layer, the cells are dome shaped. So this shows a multi-layer epithelium. The applied aspect of the bladder is the bladder is atonic, one atonic bladder. So tone is lost, so it goes on distending. Next condition important, very commonly we come across, that is the cystitis of the bladder. The cystitis of the urinary bladder occurs, as you can see, there is inflammation, and this because of the urinary tract, many times because of the urinary tract infection, and there is inflamed mucosa, because of which for the patient it is painful urination is there. There is a pain in the suprapubic region. The urge will be there, repeated urge for the urination. Okay. Another next condition, that is the stones in the urinary bladder. As we saw, the stones commonly gravitate and they come in contact with the vasi, trigonum vasicae, and very painful here. Many times, if the large stone goes and stuck in the neck, then there will be the dilatation, the urine cannot be passed, and the patient comes to you with the inability to pass the urine and distension, and there is a mass in the abdominal cavity. So that time you have to remove it. No, that is the approach through the anterior abdominal wall. The urinary bladder stones are also called as the bladder stones or vesical calculi. One more condition, that is CA bladder. So thank you all of you.